Okay, so thank you everybody for attending this presentation. My name is Okechiemeka Egwin, and this is going to be a presentation on hospital-acquired delirium. This is in satisfaction of my capstone experience in baccalaureate nursing from Vincent's University. So I picked this topic because delirium is something that affects patient outcome, and it's very stressful for the patient and very stressful for the nurses. So it's something that we could do something about. It's very helpful for everybody. This presentation is going to cover problem statement. I reviewed 5 literature, so I'm just going to go over a synthesis of that review. And this led me to some questions, ethical questions, and evidence-based practice recommendation. So first, what is delirium? So delirium is an acute change in cognition of a patient. It's different from dementia, because dementia is more chronic, but delirium is acute. So the patient kind of gets confused over 24 hours, 48 hours, that kind of thing, as against delirium that is chronic and starts slowly and builds up. Delirium is very prevalent in hospitals, not just in the United States, but basically wherever there are sick people. The incidence of delirium is in the United States ranges from 20 to 83%, and that wide range is because some hospitals have systems or processes that kind of manages it better than other hospitals. What are the negative consequences of delirium? It's a whole lot. First, patients will get confused and fall. It leads to a general cognitive decline and increases the risk of long-term care. And again, the effect on nurses, it just kind of stresses everybody out. And sometimes you're taking so much care on one patient and ignoring others because the patient is just confused, and that's very stressful. Okay, so I'm going to go over some literature that I reviewed for this. There are 5 literatures. The first one was a study titled Multi-Component Intervention Program for Preventing Delirium. The second is a novel delirium prevention bundle in mechanically ventilated patients. The third is nocturnal dexamethasone administration to prevent delirium. The fourth is targeted nursing intervention and delirium in CABG patients. And the fifth is combined non-pharmaceutical intervention in prevention of delirium. So the first one is multi-component intervention program for preventing delirium. This was done in South Korea. And what they did here was they identified a number of risk factors and then tried to modify it to see how it was going to affect the outcome for the patients. And they took out the family caregiver. They identified the family member who takes care of this patient. So they taught the family member what delirium is, how to recognize it, how to get the patient oriented, because patients can get really confused. That was part of it. Then while the patients in the hospital, they increased family support. So family members were encouraged to come to the patient at least 3 times a day, and then come with things that the patient is familiar with, maybe the pictures, something to bring them back to reality. That was part of what they did. Then there was also sensory. See, sometimes patients get so much noise, so kind of reduce noise, reduce light, those kind of things. Take shower for the patients in the evenings. Normally we take our showers in the morning, except for these patients, take their showers in the evenings. They just tweaked a couple of things to say what's going to happen to these patients when we tweak this. There were 73 participants in this study. 35 were in the intervention group, 38 were in the control group. And when they did all of this, over a 3-month period, there was an 81% reduction in delirium, which was very significant. The second study was done in, I think this was done in South Korea as well. It's like, oh, sorry, I went backwards instead of forward. This was done in India. So for this intervention, they went to patients who were on mechanical ventilation and said, okay, fine, the same thing. They tweaked a few things. They said, we need to manage their pain. So there was emphasis on pain management, increased family bonding, early mobilization of mobility. So they try to remove catheters, anything that can make the patients not walk around, and to see how the patient was going to see their delirium, whatever, in the patients. Then for this, they said no benzos. The patients on mechanical ventilation, no benzos, no antipsychotics. Let's manage their pain. Let's take out whatever is going to keep them tied down on that bed, and let us see if delirium is going to get better with this patient. At the end of the study, there was a 20% reduction in delirium. This wasn't very statistically significant, but for me, I kind of think it's a starter. Yeah, so yeah, maybe addition of something else would have helped, but at least there was some improvement. The third study was dexamethasone administration every night. This medication is like a sedation. So when they give to patients, they try to achieve a drowsy state, RASS of -2. So the patient is not exactly awake and is not exactly asleep throughout his stay in the ICU, to see if that was going to help prevent the incidence of delirium. And it actually did. There was like an 80-something% drop of delirium for this patient. This study was done in the United States and in Canada. There was a center in Boston, another center in Quebec. There were 100 patients, 15 intervention and 15 control. And there was about an 80% drop in delirium incidence. So this was quite significant, even though other studies were kind of like this medication, because it keeps patients drowsy. So some people are saying that it doesn't facilitate early mobilization. So it's something to use with a bit of care, that sort of thing. But then when a patient is mechanically ventilated, he's not exactly jumping up to work. Mm-hmm. So maybe before he's off ventilation, this could be very helpful. The fourth study was done in China and targeted nursing intervention and delirium in CABG patients. This study was for patients who underwent CABG. What could be done to make sure they didn't have delirium. So for this as well, what they did was they identified risk factors, and then they targeted those risk factors and tried to modify them. So that included pain control, early catheter removal, patient orientation, increased family visit, kind of like the first study, and see how that worked. And this one as well, there was a reduction in delirium. For the control group, there were 278 participants in this study, 141 in intervention, 137 in the control. And after the study, they found that 19 people in the intervention group became delirious, while 41 in the control group became delirious. So that was quite significant. The last one was done in Brazil, combined non-pharmaceutical intervention and prevention of delirium. For this as well, they targeted non-pharmacological interventions in trying to prevent delirium. So they also targeted periodic orientation, cognitive stimulation, correction of sensory deficits, environmental management, and sleep promotion. Again, for this one, there was a reduction as well in a number of people that became delirious. Sorry. Okay, so after looking at all this study, kind of led me to ask a question, what they call the PICO question, to say in elderly patients admitted to the, not just intensive care unit, basically in the hospital, how does the use of targeted interventions, pharmacological, non-pharmacological, family involvement, compared to the standard body of care affect delirium rates among patients? The current practice is for patients to get some benzos when they begin to exhibit signs of delirium. There's really no proactive process to prevent or minimize the incident. person. So my proposed intervention will be to screen patients for delirium risk factors, then target those risk factors to try to modify them. For example, pain control, early catheter removal, patient reorientation, increased family visits, which appears to be quite, increased family visits, minimize care-related interruption, so kind of cluster care, comfortable nursing, monitor for sleep difficulties until hospital discharge. Again, I think we can also give the dexmedetomidine when there's really, they don't have to get up so much, kind of like keep them comfortable at that state before they have to become active. Say what process can we use to do this? I was thinking about the plan, do, check, act process, which is a PDCA, which is like a continuous iteration process of trying to make changes in any organization. So this will include the plan, what you want to do, whose intervention you want to do, select a group of people to do, maybe do it on a particular unit, see how it works, check to see was this effective, and then roll it out to the whole organization. Okay, so that's presentation in a nutshell. But I would like to ask some questions. So, do you think the intervention is feasible here in Union?
To prevent?
Yeah.
You think it's feasible?
Yeah.
Yeah. Because, I mean, especially with the family members staying in.
Changing.
You know?
They're encouraging to stay, let the patient family stay if they're really confused. So it's like.
So getting family members involved is a key factor.
Oh, yeah.
Yeah.
So that we need to identify somebody and then try to train them, because you know what I mean? They have to know what it is, what to look out for.
Yes. Or even getting them like one-on-one sitter, like a person that is there to make sure that they have their BiPAP on, to make sure that they're not falling or anything. Because there's so much the family members can do too, right? So if you have a sitter, they will be more educated how to deal with these situations as well, because they're going to be more trained to take care of them.
Okay, so that's it. So these interventions, how do you think it's going to impact the nurse's ability to provide holistic patient care? Do you think it will help? If you get family members more involved, get one-on-one sitters.
Yeah.
Oh, yeah.
Because you're not spending all your time in there.
Time in and out, telling them, and their oxygen dropping. Yep. So, the more hands you get, so they're basically like hands that you're having for your own selves to help you out with the patient care. So, try to get as much as you could for that patient to help them recover from it.
But do you think we have enough resources for that? For the one-on-one, for all of that, do we have enough resources in Union, you think?
I mean, we do get sitters for suicidal, right? We
Yeah,
do manage to
sometimes,
get
but for a
it.
confused patient, they have
And
to
then, but it's just,
And then if you ever want to get the person placed anywhere, they can't have a sitter for 24 or 48 hours, depending
or
on the
have
place.
the medicine. So
Yeah. Or
So the
not be able to
medicine is
get
a good idea?
It helps.
I think that will probably help, but I don't think we will be able to do that up here. They probably do like some, like you said, ICU, after they come off the bed, like that one medicine. I don't know how strong, how strong that is, how, if they need to be on monitors for that or not.
And then when you're talking about the medicine, you talk about the
side effects as well.
Age,
Sometimes
yeah.
those
Yeah.
help, but we can't use them. Sometimes, like, you have to be without them for 24 hours to go to a facility.
Yeah, and then even with the medicine, like he said, you gotta take into like their
age,
age,
consideration, age of the patient.
the other health, things that's going on. They might have kidney problems, liver problems, so the medicine might make it worse.
Yeah.
Because
Then,
like some of them that have a excretion problem, because we talk about metabolism, absorption, and all of that, and excretion. So like the elderly people, because of the decrease in their metabolism system. It will hold back some of the toxic, hold back the medicine, and it will create toxicity because they will have problem in excreting them through the urinary tract, and that is the reason why. And delirium is very common with elderly people also because of UTI and all of that. So we should know that. That aspect. So I think one-on-one, like to implement one-on-one theater, like you said, to help some of those things before we
Or
can
even
discharge
having,
them.
family just
Family is the
there.
best.
Family.
Yeah.
So, yeah, so the non-pharmacological family, you think that's the best?
I feel like that'll be the best.
Yeah.
Okay, so who do you think can use as an advocate to implement this intervention? Who can be the advocate here?
Each caregiver, or any caregiver,
And what I mean, manager-wise?
manager-wise.
I mean,
Nurse,
like
we have
me as
nurse
a nurse,
educator.
I could call the hospitalist and say, hey, you know what, this is the situation and I need more than this.
Case management,
Case
social
management,
workers.
yeah. Because basically, there was a study saying that anything can cause delirium. Even, having a UTI, staying a long term in a
Even the smoke
hospital.
can get delirium.
It could be anything that causes these problems. So, yeah, I was reading through the list.
You're
and
the
there's
first
like
one
basically
to have a
anything
delirium.
could trigger that delirium.
Yeah, I have a
So-
checklist on that delirium thing.
It's like a
But
long
yeah,
list.
there's a really long list on what we can.
Yeah. So, like, I had to do one of the research paper, and my teacher was like, yeah, like, basically anything for elderly. It could even be the room color, too. And I'm
Because
like,
it's a change
it's
from
like
their
a trigger.
normal environment.
Environmental, yeah.
Yeah.
And already a thing.
Alrighty. It says, does the workplace have any process in place for implementing new processes? But if we're all looking towards the family one, so I guess.
And they let us, they tell us we can, call
Yeah.
family and how
Well,
we
we've had patients that when their family's with them, they're just fine.
Fine.
You don't do anything, and then they won't be there the next night. The patient will be by themselves, and we're in there every 5 seconds.
Yeah.
So, yeah.
And another implementation when you
I
talk
don't
about
think-
family, that there's one patient I've been to their room, and the family has this slide picture, there's a screen.
Just something.
Yeah,
Screen.
something to bring them
That's
back
like-
home,
yeah.
right?
That help them because family will not always be there, you know what I
Right,
mean? Some
right.
of them they travel California and all of that.
And we do have a delirium thing, because I know like the ICU, they tried on it.
Yeah,
I
they
know
have
all the
delirium,
time,
yeah.
the
ICU
confusion scale,
come,
yeah.
yeah.
I see you doing.
And then like if you look on our chart and we got something on there too that like low lights,
Mhm.
you
Right.
know, it's a whole bunch of other interventions on there
Right.
that they have in there.
Or if
So
you
we-
put somebody in restraints, like you have to give the list of what you've done before,
Yeah.
like.
Yeah, most of that
Yeah.
stuff is on for like the delirium part,
Mhm.
yeah. So they do have something here.
Something in
I think,
place, yeah. Okay. It's good to know. Okay, thank you everybody. Thanks for being a part of my journey.
Yeah, it was a pleasure. And thank you so much.
Thank
You need these back.
you. No, everything's fine.
Yeah. Make sure I listen to the camera.
Smile.